Rahim. So I have talked about myopathies. In that I have gone through the myasthenia gravis. That is gonna patient is gonna come with the easy fatigability. And if we talk about oddly enlarged muscles, so we're gonna think that the patient is having congenital muscular dystrophy. So I have gone through the Becker's muscular dystrophy and Duchenne muscular dystrophy and facioscapulohumeral muscular dystrophy, right? And after that, if the patient is having pain at rest, so we're going to think that the patient is having myositis. So I have talked about the polymyositis and dermatomyositis and incline body myositis. I have talked about these things, right? And after, our next topic is if the patient comes with the muscular weakness and if we see the contraction in that muscle, if there is sustained muscular contraction, so we're going to think the patient is having the myotonic dystrophy, right? And if we talk about the patient is having sudden onset myopathy, so we're going to think the patient is having the electrolyte imbalance. So I'm going to cover the myotonic dystrophica and hypokalemic and hyperkalemic periodic paralysis in this video, right? And this is the last topic that I'm going to discuss in the respective topic, right? So I'm going to discuss these two last topics today, that is myotonic dystrophica and hyperkalemic and hypokalemic periodic paralysis. So let's talk about myotonic dystrophica. Right, so let's talk about myotonic dystrophica. So what happens in this condition, this is basically an autosomal dominant genetic disorder, right? So that is characterized by there is continuous contraction of the muscles, right, due to delayed relaxation. There is delayed relaxation after, even after voluntary efforts. If these patients usually say that pani pani to pee leta hu lekin I cannot put back the glass, right? So pani to pee leta hu lekin glass वापस नहीं रख पाता, right? Because of sustained muscular contraction they keep holding the glass, right? So there is basically chloride channelopathy, right? This starts at 25 years of age, right? And there is usually we're gonna see the muscular weakness, and there is distal muscular weakness in these patients. And if you check the reflexes, those will be intact. Along with that, patient is gonna have the myotonic contractions, right? Okay. Usually when we see the if there is increased tone, so reflexes should be brisk, right? But in this case patients, the reflexes will be intact and there will be muscular weakness, right? And along with that there will be myotonic contractions. And these people usually have the specific features, like they have the cataract in these patients, that is Christmas tree appearance cataract, right? And if we check there will be frontal baldness in these patients. Their face will be long haggard face, right? These are called as myopathic facies, right? If we check the upper lip, so there will be tenting of upper lip. And along with that they will have the low IQ, and they also gonna have the type 2 diabetes mellitus, and they will have cardiomyopathies and conduction defects. And along with that they're gonna have the infertility, right? So treatment is just supportive. We're gonna give these patients that is phenytoin, right? Only drug one that can help in these patients, that is phenytoin, right? So that's about the myotonic dystrophy, right? So basically there is sustained muscular contraction in these patients. We're going to differentiate it from the hyperkalemic periodic paralysis. I'm going to discuss it just right now. Okay, so let's talk about hyperkalemic and hypokalemic periodic paralysis. So to understand this topic, so this is basically an autosomal hypokalemic periodic paralysis is basically there is in these patients we're going to find the hypokalemia, right? Along with that it occurs in in periodic waves in the wave form, and we're going to see the paralysis in these patients. So this is basically an autosomal dominant condition. There is the sodium channelopathy, right? Sodium channelopathy in these patients, and sodium channel that is defective in this patient is called as SCN4A, right? So we can see in the nerve ending we have this channel that is called as sodium potassium channel. This is not sodium potassium ATPase. That function, the function of sodium potassium ATPase is opposite to that of this channel. So this channel is responsible for to take in the sodium and to remove the potassium out of the cell. So we see that when there is when we need, usually we say that the cells are bag of potassium, right? So cells are bag of potassium, so there is maximum concentration, that is 135 to 145 milliequivalents equivalents of potassium that is present within the cells. And outside that, if we see in the blood, so potassium concentration is about 3 to 5 3.5 to 5.5 milliequivalents, right? So when there is decreased efflux of potassium, so there will be hypokalemia. When this channel is defective, so there will be hypokalemia, right? So when there is this channel is not going to work, right? So there will be decreased sodium influx in these patients, and there will be decreased efflux of potassium in these patients from the cells into the blood. So plasma level of potassium is going to lost, so there will be hypokalemia. That's why we call it as hypokalemia. And these symptoms usually get worsened by food intake, right? When they intake the food, so what's going to happen? Insulin is going to released. When insulin is released, so it going to internalize the potassium into the cell, right? So these patients already have hypokalemia, and when the insulin is going to internalize the potassium into the cell, so hypokalemia is going to get worsened in these patients. So these patients will have the symptoms of hypokalemia, right? All right, so we're going to see there will be sudden onset quadriparesis in these patients, and if we check the reflexes, those will be intact, right? Okay, so right, so this is associated with Graves' disease, right? And onset is usually in 20 years, and it usually remits after 35 years. And duration of attack, it's going to happen from hours to days, right? So let me okay, so okay, right, so let me revise this thing from here. Okay, cells are bag of potassium, so when this channel is defective, so there will be decreased sodium influx, and potassium efflux will decrease. This will lead to hypokalemia. And when this channel don't work, so there is defective depolarization and repolarization, right? And that is going to cause the weakness and paralysis in these patients. So these symptoms get worsened by carbohydrate rich meal intake, right? So weakness after eating food, that happens because of the increase in insulin. That is going to cause the potassium influx into the cell, right? This is going to cause the hypokalemia, which is going to, and the weakness get worsened. So that's why we call it as periodic, right? So what we need to do in these patients, we're going to check the serum potassium level. It might be normal, it might be low in these patients. If we get the CPKMM level, that will be normal. Everything thing is going to get normal, right? So we need to get the genetic studies in these patients, right? So what we can ask the patient to decrease the intake of carbohydrate rich meals, right? So for prevention, we can add a drug that can help in these patients, that is acetazolamide. So it is gonna improve this is gonna activate the calcium. There are some channels that are called as calcium activated potassium channels. So this is gonna improve the potassium conductance and improve the potassium efflux out into the bloodstream. So this is gonna treat. That's how we can treat the hypokalemia in these patients. So low dose of acetazolamide can be used in these patients. Along with that, we can add the tablet Neo-K, that is potassium, and we can give these patient injection potassium chloride and in diluted form over hours, right? So that's all about hypokalemic periodic paralysis. Alright, so before going to hyperkalemic periodic paralysis, let's we there is one thing that I need to mention here, that we have got two types of hypokalemic periodic paralysis. There is type 1, and then there is type 2 hypokalemic periodic paralysis. So type 1 is associated with calcium channel defect, and type 2 is associated with sodium channel defect, that is SCN4A, right? Okay, let's talk about hyperkalemic periodic paralysis, right? So when this same channel, that is SCN4A, when it's gonna hyperfunction, uh, in hypokalemic periodic paralysis there is decrease a function of SCN4A. This channel is not working. So in this hyperkalemic periodic paralysis there is increased functioning of SCN4A. So what happens in this condition, there is, if I draw that again, so we have this nerve ending here, so we have this channel here, that is, this is going to cause influx of sodium and efflux of potassium. So when this is going to cause efflux of potassium, so there will be increased potassium available, in the bloodstream, so we'll have increased amount of potassium. And when there's increased amount of potassium, so there will be, delayed relaxation of skeletal muscles, and patient is going to complain of the cramps, right? And this delayed relaxation of muscle is called as myotonic, right? So if we're going to ask the patient to squeeze our hand, then they won't be able to release the hand, right? Because of the delayed relaxation, right? So we're going to differentiate it from the myoclonus, that is involuntary jerky movements, right? So that we're going to see in various CNS disorders. And there is also another similar name related to that is called as myokemia. So there is periocular muscle fluttering, that is called as myokemia. So what happens in this condition, in these patients, they these patients are going to complain of the cramps, and there will be delayed relaxation of the muscles. So these symptoms get improved after carbohydrate rich meal intake, because of the increased insulin. So insulin is gonna cause the this increased amount of potassium. This gonna this will from it will insulin will internalize the potassium into the cell, and there will be decreased amount of potassium available in the bloodstream. So that's how symptoms are gonna get relief in these patients, right? So onset is usually in the childhood, right? If you compare that with the hypokalemic, so it will be in 20 years, and it remits at 20 years, and this disease remits at 35 years. So duration of attack is hours to days in hypokalemic, but duration of attack is less than 2 hours in these patients. So we need to do the same workup for this patient as well, right? So we can go for genetic studies in these patients, and we need to treat the hyperkalemia in these patients, right? When we usually depotash, that is actually a wrong term, right? So we can use the calcium gluconate, and we're going to use the insulin drip, right, and ventricular nebulization to treat this hyperkalemia in these patients. And we can prevent this by giving a drug that is called acetazolamide, same drug that we used, but here we're going to use the higher doses of the acetazolamide. And there is an antiarrhythmic drug, right, that is used for ventricular tachycardia, that is mexiletine. We can treat this disease by mexiletine, right? So I hope I have covered. So we're going to differentiate hyperkalemic periodic paralysis from myotonica congenita, myotonica dystrophica, right? So along with that, we're going to see the delayed relaxation in both of these cases, but there will be additional features in the myotonica dystrophica, right? So that's all about the hyperkalemic periodic paralysis and myotonica dystrophica, right? So we're gonna start the neuropathies in the next video, right? So that's all for the approach to the muscular weakness.